opioid epidemic that we face today is something that is very important to me. My mother suffered from an opioid addiction and later died of an overdose. Opioid overdose is the leading cause of injury-related death in the United States. And I feel like with advancements in medicine that we have today, this could be an epidemic that could easily be lowered by proper education and available resources to the public. The nurse's duty is to protect and advocate for the patients and community. If these medications are being prescribed, we as nurses are educators and have a duty to the patient to provide safety education and overdose prevention information. A lot of the information, statistics, and research that is available shows that Naloxone take-home kits serve a great purpose and save lives. But it is flawed due to people not carrying the kits at all times, not reporting the use of Naloxone due to fear of repercussions. The opioid antidote has no known side effects and causes no adverse reaction if it is administered to someone that is not suffering from an overdose. So the risk of the drug is very low. Making Naloxone readily available could minimize deaths due to overdose. My first research article by Katawanda 2018 is about a study conducted in North Carolina aimed at patients that are currently attending a medication-assisted therapy or MAT clinic. This study shows the issues with using Naloxone and if people who have received a Naloxone kit are utilizing it. The current death rate due to opioid-related overdose in North Carolina is 15.8 per every 100,000 people. And in a 17-year time frame between 1999 and 2016, a total of 12,000 people have died due to an opioid-related overdose. According to Katawanda 2018, it also states that Naloxone is noted to have no adverse reactions in someone who is suffering from an opioid overdose. It requires very little training to use and is very effective in reversing the deathly effects of an opioid overdose. Senate Bill 20 and 154 protect a person that call 911 to report an overdose from persecution if they are under the influence or in possession of a small amount of drug paraphernalia. This also protects the victim from overdose from being persecuted for the same thing. A standing order was signed to authorize any pharmacy to distribute Naloxone to any at-risk opioid user or a family member of an at-risk opioid user. The North Carolina Harm Reduction Coalition, or NCHRC, distributed 62,000 free Naloxone kits. This led to 10,369 reversed overdoses. Katawanda 2018 performed a 15-part study aimed at analyzing why some of the recipients of free Naloxone kits distributed throughout select MAT clinics are not using them. When recruiting for the sample, they used a random approach, visiting one different clinic every couple of months to ensure none of the participants were repeated. The participants must be 18 years or older and familiar with Naloxone. Once the clients agreed to participate in the survey, a verbal consent was obtained and the participants completed the 15-part survey. 100 people participated in the final survey. Of the 100 participants, 58% were women and 42% were men. 29% of the people that had a kit available when witnessing an overdose, and 89% of those individuals used the kit to reverse an overdose. 94% of the people agreed to calling 911 after the administration of Naloxone following an overdose, and the remaining 6% attributed not calling 911 to not trusting the police and preferring to take the life-saving actions upon themselves. Naloxone kits are not just necessary tools for first responders, but a tool for the public because the vast majority of overdoses occur with a witness present. Katawanda 2018 also points out that the reason why many people do not have a kit is because they do not know how to obtain one. The people that have been given a kit have received them through outreach programs such as NCHRC, rather than seeking out and obtaining one themselves. 19% of people in possession of the Naloxone kit reported carrying it with them at all times, while the remaining population did not carry it on their person, attributed it to not anticipating being around drugs or people who use drugs, forgetting to bring it with them, or a common issue among the male population is that they couldn't get the pouch to fit in their pocket and it was not easily carried. One of the concerns noted is that if lay people have Naloxone kits readily available, it will encourage them to not seek help by calling 911 after an overdose. Good Samaritan laws protect individuals who do seek medical attention from persecution. A journal by Green 2018 focuses on the potentially negative aspects of making Naloxone easily available to an at-risk opioid user because it could encourage opioid abuse when the fear of death is no longer a risk. As more states approve legislation to make naloxone readily available, researchers wanted to analyze data from a public health standpoint of how this may be impacting communities. One study indicated that there was a 14% increase in opioid-related deaths, suggesting that this was due to an increased use of fentanyl. They also concluded that after the legislation was passed, there was an increase in opioid-related crimes. Green 2018 also states an increase in emergency room visits could be expected with an increase in naloxone administration because people are urged to seek medical attention after the administration of naloxone, the antagonist drug. Emergency room personnel also argue that the naloxone is not an enjoyable drug for the person receiving it because it precipitates an immediate withdrawal. So this would not encourage using the naloxone as a crutch. The doctors argue the administration of naloxone from a public health standpoint, whereas the economists disagree and argue that this is enabling and producing higher rates of opioid overdoses. Due to the large number of opioid overdoses in Scotland, a program was started for take-home naloxone kits. This began in 2005 and is a funded public health policy. Bird 2014 states that in 2011, Scotland became the first country to introduce take-home naloxone as a funded public health policy. When performing the study, it is noted that in order for the naloxone to be an effective treatment for an overdose, the distribution of the take-home naloxone must be vast and cover a large population. The study aims at distributing the take-home naloxone kits to specific at-risk populations, such as people being released from prison, patients being released from the hospital with history of heroin injection, and admitted misuse of drugs, alcohol, or benzodiazepines. Bird also states that before and after evaluations of naloxone training have consistently demonstrated that trainees' knowledge and their confidence increased about the size of the overdose and showed that the knowledge gained was retained adequately when the trainees were retested 3 and 6 months later. This stresses the importance of education with naloxone distribution and administration. For the THN program to be effective, the naloxone needs to be present where the drug overdoses are taking place. This is either on the person supporting or attempting to save a life, or prescribed to the person that has an overdose. With adequate training and distribution of naloxone, the death rate due to opioid overdoses decreased among high-risk individuals, according to Bird 2014. My final study uses a cascade of care approach. Tobin 2018 states that we applied the cascade concept to identify gaps, uptake, and use of naloxone, awareness, access, training, possession, and use. The distribution programs have shown to have a positive impact on the opioid overdose rates, but key factors that contribute to the success of the program are education and having the drug readily available. Administration of naloxone is aimed at high-risk individuals using heroin, fentanyl, and prescription opioids. Tobin 2018 conducted a survey that was presented to people over the age of 18 that had a lifetime use of heroin. 353 people were recorded. The study was performed as a private interview. The interview consisted of 10 questions regarding awareness, access, training, use, possession of naloxone, personal experience with overdose, demographics, and drug use characteristics. The information from the survey indicates that the public is well informed and educated, but that the gap in naloxone is the public not carrying it on their person at the time of an overdose. A stigma is noted to the use of naloxone as it could indicate that the person is a current drug user. This is inhibiting the refilling and open carrying of the naloxone kits. For my own study, it would consist of the administration of naloxone kits to people who are high risk of opioid overdoses, such as people who are prescribed opiates or have a history of opioid addictions. I would administer the naloxone kits to these people and to the people that are included in their support system surrounding them. I would start by posting information around the public health department about the availability of naloxone kits and training on how to use them. I feel that posting information and letting the clients approach me about the information would make them feel more comfortable, willing to speak with me and receive the training. When a person contacted me regarding the information, I would hold a training session on the administration of the naloxone and provide the person using opioids or the support person with a naloxone kit. Within the kit, I would have 2 intranasal vials of naloxone, 2 intranasal atomizers and adapters, a clean pair of gloves, the information pamphlet that is contained within the box of naloxone, information on how to recognize an overdose, and a detailed set of directions for administration. A common problem for the kit not being utilized is because it is not being carried with people. I would like to have it in a small hard case pouch that can easily be carried in a man's pocket or a woman's purse, ensuring that it would remain on their person. The importance of still seeking medical help after the administration of naloxone and when to administer the medication would be my 2 main teaching topics, as well as the Good Samaritan laws that protect the patient or family from being persecuted after seeking help from an overdose. I would like to see that the time frame span over 2 years to be able to see the maximum possible improvement from the entire community. I would compare the death rates and recorded overdoses from previous 2 years to the current rates after the administration of the take-home naloxone kits. I would expect for the death rate due to overdoses amount to decrease substantially with the administration and teaching of the naloxone. For my poster, I have my study, my results, detailed steps of administration when doing it intranasally, and pictures to go with that. I have what I would put in the kit, the type of carrying case, and some statistics just for the state of Kansas and opioid rates. That's it.